Welcome to LECOM Health Matters. Our guest today is the quintessential Dr. Jim Caputo. Jim has so many hats that I can't tell you what he does, but it all has to do with vaccines, taking care of people, testing people, and being a wonderful practitioner. So Jim, thanks for being with us. And sorry, I don't know all those titles, but he's giving shots. That's what we want to talk about today. And so Jim, welcome to LECOM Health Matters. It's good to have you with us.
Thank you very much, Monsignor. I'm learning that if I don't back up like they did on the Three Stooges, when you volunteer, you can end up wearing just about any hat.
This is true. Jim, obviously, we're going to talk today about vaccines and we're going to talk about COVID. But let me do it backwards first. Where are we as a nation and as a community relative to COVID? I think there's great misunderstanding. Some think this thing is all over. Some think it's rampant, and you're the expert. So help our audience understand basically where are we relative to COVID, infections, hospitalizations, and spread. Not necessarily in that order, but nationally and locally. Where do you think we are, Jim?
And I'm not going to go with exact numbers, but to try to get some things for scale, excuse me, some things to scale, because there's a lot of numbers that get tossed about. We talked about at times how many positive versus negative tests, how many hospitalizations, how many people on ventilators, how many people dying, and there's so much data, there's so much confusion, and it takes a degree in statistics to analyze what's going on. But from a standpoint of infection and infection prevention, infection treatment with viral illnesses in general, we were confronted initially with a virus, which is nothing new. We have thousands of them that infect us, and they're quite commonplace to have them and have some without even realizing. Influenza has been lethal at various times in our societies and societies before. We've made leaps and bounds of improvement on the lethality side of that by using things like vaccines. But like all of Mother Nature that God's given us, they have the ability to, the virus doesn't think for itself, but, all of our creatures have created better ways to make their life, essentially. And sometimes it's at the expense of other ones, and viruses, bacteria, people, fungi, they all kind of coexist. Viral infections are not like bacteria and molds in that they're technically not alive, but they really contain a blueprint. What I tell my students is a virus really is something that's kind of like a blueprint for something. And to think about it, when it moves in, it's like the guest that came into your house. It's like the guest that never left. And what they do—
Some of your relatives you wish left?
Now, I'm not going to name any names here, but they can figure it out. Because a virus uses everything in your body to create more virus particles to perpetuate itself. So I equate that to somebody, you invite them in, or maybe you didn't invite them in, they come in and they take their shoes off, but before you know it, they're using your toothbrush, they're borrowing your underwear, they're using everything that they have. So the machinery that they use to replicate is a lot of the machinery that we use to build the stuff and the proteins that we need. So when they infect us, and we try to use drugs like we do with typical antibiotics we take for bacterial infections, sometimes we run the risk of damage to our body. And so that's why some of the treatments that we've talked about for antivirals even have been some things that, yes, they might impede the virus from spreading or impede them from, replicating, but they can be dangerous to our cells too, because the virus uses a lot of our machinery for it. Now, our body has a tremendous immune system and a tremendous ability when it's healthy to defend against these things, and it does a fantastic job. And what it does, the immune system, I call it when it gets exposure to something, it's kind of like when you need to do something, you make a sticky note for it for the future. And then when it comes around again, it's like, oh yeah, I remember that. And your body's immune system makes these kind of sticky notes. It remembers what was there. And so it has a foundation for treating that infection. When COVID came up, there were no sticky notes. There was no pattern. There was nothing to use. So the immune system saw something new. This virus, being brand new, had, unfortunately, some very serious effects associated with it. That really was one that had the ability to cause death in individuals, not only unhealthy ones, but even healthy ones, strapping young guys, the young, healthy folks. And that is, it also had a position of being very communicable. So some things we have, we worry about things like we see things in the news like monkeypox. Well, that doesn't have the communicability of other conditions, TB, various conditions. People get them, they get MRSA staph infections, but I'm not going to shake hands with you or cough on you and give you MRSA. This is much different. This was very highly communicable, and it possessed those two qualities of being highly communicable and being lethal, which are a little bit less usual in nature because things that are very lethal tend to kill themselves out in the population they start in, like animals. In this case, it didn't. Rapid spread, rapid transportation in our world now. For you can be on the other side of the world in 12 hours. It caught everybody by surprise. Because it's a virus and because the first flu virus in some form that circulated a few thousand years ago, it's still out there in some form. So it's going to be present. Now, how much of a danger is it going to be, though? Because we run into a lot of infections that eventually aren't dangers. The way that we create them into not being dangers are by having good treatments for them. Good treatments can be drugs that we use to treat after an infection, or in the case of vaccines, Dr. Jenner learned long ago with milkpox and milkmaids, or cowpox, excuse me, and milkmaids, that milkmaids who were back in the 1700s milking cows, and cows that got a disease called cowpox, again in the whole line with monkeypox and smallpox, were not getting smallpox. Smallpox was devastating in the late 1800s. And through some experimentation, we found the relationship and things like that. And eventually we created hypodermic needles and all those kind of things and learned about vaccination. And before you know it, we had a smallpox vaccine, blah, blah, blah. And that does protect you against monkeypox because they're related. But because of that relationship, what was able to be created was an immune system readiness that's unlike any other disease treatment. So we get high blood pressure, we get diabetes, we discover them, we treat them for the rest of your life, typically, with medications we take on a daily basis. A vaccine has the ability to mitigate either a disease from either occurring in the first place or greatly dampen its damage that it's going to cause. So they are one of our greatest advances in medications. And unfortunately, one of the shortfalls I think we did in because of the need to do something very quickly with COVID, we perhaps as a nation, as healthcare providers, as whatever we are, we're not able to do a very good job of the educational process of how important that vaccination process is in treating a disease like that. So the vaccines are really integral.
So Jimmy, given that, where are we now relative to infection and relative to spread?
Right now, we've had tremendous exposure of folks to COVID. If we look at population, we're at the point where, and I don't know what the exact numbers are, where if we look at folks that have had COVID or had COVID vaccinations, we're going to be headed towards numbers that are going to be pretty close to 100% over the course of the next couple of years. We might be at 70. If we look at vaccinated population, say in the United States, at 70%, a good portion of that of our population has had COVID. We're probably in the 80-90% of people that have had either one of the other and therefore have some foundational immunity, which means when they do get COVID, the likelihood of them having serious illness diminishes. The likelihood of hospitalization, of using a respirator, to breathe and stuff, severity of illness decreases. But there's always going to be in a population what I kind of term, unfortunately, the low-lying fruit, the individuals that have pre-existing conditions, that have immunocompromised, that are in positions, and we can't always look at them and say, oh my gosh, you're immunocompromised. I can tell by looking in your eyes. There's a lot of folks that we don't know. We know folks that are on chronic medications that are going to be in that case. So there's always going to be a population. We know things like flu tends to pick on still the elderly, but then this past year it actually picked on a lot of young kids, and so babies were a population that was subject to a lot more disease.
So is it fair to say, Jim, we're not over this then, are we?
No, we're not over it. What we're entering is kind of another phase where, and we'll liken it to influenza, we can liken it to colds, where we're going to have a condition, a coronavirus, and there are other coronaviruses that are colds. It's going to be integrated into something we're going to see as an infectious disease. How it progresses in lethality and how serious it is, is dependent a little bit on Mother Nature and how things evolve, but it's also dependent on our practices that we take. Our other things are we do masking, appropriate social behaviors. Vaccination is still a critical thing. And it's how we handle it. It's going to be something that we will honestly be able to deal very well with it.
So I think it's fair to say that, as some have suggested, obviously incorrectly, that we're still dealing with this. It's not over. There's still the virus in our environment and we're spreading it. So as you said earlier, there are ways we can fight this disease. Now, I think if you could explain to us the difference between vaccination, boosters, bivalent, I think there's so much out there,
Sure.
which I think is a tribute to medicine and science that we produce very quickly. I mean, Jonas Salk took 20 years before the polio vaccination was in circulation. So we did this in a year, which is hats off to science.
It's a miracle.
The rapidity of it has confused a lot of people. So what's the difference between a vaccine, a booster? What do I need to get now?
Okay, so there's three things of major methods of attack we use as far as any kind of medication or treatment that we use. So vaccines are one that are integral. That's the thing that basically gives us a little dose of something that's kind of, if you think about it as a piece or a part that the immune system is going to recognize and do something about and have some ability to be a prophylactic to keep you from getting it. Then we have two types of treatments that we use for people that get it. One is kind of like a substitute for your immune system that we use in very ill people or people at very high risk. And these are the things we call like the monoclonal antibodies that we used early on. And now we have commercial drugs that we can use in people that maybe don't have a good immune system. We can use them ahead of time if they're going to be subject to it and been exposed, or we can use them as part of our treatment. And then we have the drugs that are the antiviral drugs, and think of those as being drugs similar to the things, the antibiotics that we take for infections, for ear infections and throat infections, stuff like that. So those are things to take when the infection is set in already, but we want to control it and maybe make it last a little bit shorter and make the symptoms be a little bit less severe.
What's the difference between a vaccine and a booster? Like in my personal case, I got 2 shots. I assume that was the vaccine.
That was so in each case, so all of those, so the initial series, any of the shots afterwards, the booster, what we talk about now, we'll mention the bivalent booster. These are all the vaccine. What we find is with infections, and particularly with viral infections, our immune system needs a few sticky notes because it makes a sticky note, just like the one on your desk or your computer, somebody opens a door and it flies away. The sticky notes last for a period of time. The body needs a little bit of a reminder. Once it's formed that baseline immune reaction, it makes liquid things in the blood, and we call those antibodies to fight an infection. And then it makes some other cells. And think of those guys as being kind of like the artillery guys in your military. These are your guys that are sit back, kind of parked with the stuff, and they know where they have to aim and how they have to do stuff. They're kind of sitting back waiting for a target to happen. And so they have their sticky notes programmed with stuff. But again, these guys get a little fatigued after a while. They get, like you and I, Monsignor, sometimes they get up a little bit in age and they need some reminders. So the boosters,
so basically,
the boosters are those reminders.
In terms of the series, Jim, we had the 2 vaccines, which hopefully people our age got. Then we had the 2 boosters, which hopefully people received. And everybody is eligible for those 4. Is that correct? Children or different?
Yes. So if we talk about adults, that's where we start. If that's where you started, that's where you were. Right now, we are still using boosters. And the thing that's different about the booster that we are able to use right now is because this virus has decided, there's a couple of things it's going to do to try to evade our immune system. It made a couple of changes in its blueprint to change what they call its spike protein part, which is not that important to know what part it is. And what we did was we tweaked this vaccine that we have. So we still have a vaccine, but we made half of it match the blueprint of what is out there in about 98% of the infections that occur right now. And that's that strain we call the BA4 and the BA5. The good news is that, as we've seen changes that have occurred in the last year and a half with the vaccine, we've seen a number of different names given: alpha, beta, delta, Omicron, blah, 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 all of these things. There's been pretty good progression of different changes and a lot of changing that's occurred. There's been, very fortunately, somewhat of a stability plateau. And what we see with this BA4 and BA5 is there's not a whole lot of new guys lining up to take its place. And so the vaccine that we've created now, that is it's a vaccine, but it's going to boost someone's immunity that has to have the initial series first. And we'll talk about that as far as the order of vaccination. But this particular booster, which is a vaccine, contains 50% of the original strain because it was very effective at stopping deaths and mortality and hospitalizations. So that's still there. What we hope we've done now is included the other 50% that's a little bit more specific for that license plate being carried by this BA4, BA5. So we see that our antibody levels are higher against this new strain.
So, Jim, if you could outline what the series should be for a 60-year-old adult.
Okay, so if you already started your vaccines and you've already had any of the vaccine, had your initial series, which for most were 2 shots, you may have had 1 or 2 boosters, depending on your age. You could have had more if you have immunocompromise. That is what we would start as your foundation for. You would, as long as you are at least 2 months away from having any of your initial series and any of your previous boosters that you've gotten prior to this past month, you would be eligible for what is called a bivalent booster, which is very similar to the booster you received before for half of it. The other half, you can call it the new and improved half. So and that's the part that's giving you the edge.
Let's assume that somebody got 2 vaccines, 2 shots, 1 booster. Let's say they got that 1 booster 4 months ago, and they're asking themselves, do I get another booster or should I get the bivalent?
Well, the only thing available to boost you with will be the bivalent booster. Well, so that's going to be the only choice, because that's an improvement. Now, folks that have had no shots at all for COVID, you won't be able to hop into the vaccine that we call the bivalent, because it's important to get that foundational immunity. So we will give you one of the original foundational vaccines, Pfizer, Moderna, and a new player entered called Novavax. It's a little bit different, but any one of those can be used, and you'll still get the same shots that everybody got back in January of 2021. But going forward, after that, you will be able to receive the booster shot. Will be we'll call it new and improved version.
So just to review, Jim, because I want to make sure that I understand this, and I think especially for our audience, if you had the 2 vaccinations and the 2 boosters, and the second one, let us say 2 months ago, 3 months ago, you can get the bivalent. If you had the 2 vaccines and 1 booster 3 months ago, you'd get the bivalent one.
Correct.
If nothing, then they'll go back and start you off with the base vaccines.
You got it right on the money. Okay. And no matter what vaccine you received in your original series, Pfizer, Moderna, Janssen, or in some cases, this Novavax, the preferred is to use one of the bivalent, as we call them, mRNA vaccines, which is Pfizer or Moderna's new and improved model of bivalent.
Should you stay with the same company if you had Moderna all the way through? Should you stick with that, or Pfizer?
It's recommended in the initial series that you stay with, in the first of the 2-shot series, but there is nothing wrong with changing. We don't know of any advantages, and we don't know of any disadvantages. Theoretically, is there an advantage? Perhaps. Where I usually guide people is I ask them, on the initial shots that you had, whether they be Pfizer or Moderna, was there anything untoward in those reactions that you received? And because of that, would you like to try the other to see if it's better? It's not like picking out a pair of red shoes and a pair of green shoes or something like that necessarily, because we don't know when we randomize outside of a trial and really write stuff down what happens. But there's nothing wrong with changing over boosters for something. Perhaps someone had You know, I've had a couple of people that have encountered things that are not very serious, but things like skin rashes, perhaps. There's a good reason. Hey, I got a rash, you know, maybe I'll try this other one.
Hey, Jimmy, we're starting to run out of time, so I want to
Mhm.
move along. But how
Okay.
does the flu shot fit into all of this?
Flu shot again, you know, that's an integral part. And we worked in things like the swine flu into our flu shot, so it's incorporated. The plan will be in the future, and it was for this year, to incorporate this COVID vaccine into a flu shot and create something that really is going to minimize our impact on society. And the folks that get a flu shot, they'll be able to get a flu shot, COVID shot, hopefully for 2023 when the season rolls around in fall. Very important though to get flu also, because this is complicated in fall. We're going to be trying to figure out who has flu, who has COVID. Treatments are different. If we can immunize both of them, get as many people immunized, because we know the behaviors that lead to flu or COVID are the same between them. When we were masking, we saw less flu, less COVID. If we vaccinate for both, we're going to have a better outcome. So
I think
definitely.
what we're suggesting to our audience is do not ignore the flu shot if you got a COVID shot. You need
Absolutely.
both. Because I believe that there's some confusion out there. People think, oh, if I get the COVID shot, then I really don't need the flu shot. But you're
Right.
suggesting that the research tells us we need both.
Yes, very important, even probably more important now, because diagnostically, we're going to have to figure out our treatments are different. All the patterns of spread are the same with them. And, you know, they're going to travel together like colds and stuff like that eventually. And so it'll be great once we have them all incorporated into one. But that flu shot is very important for everyone as well.
Can I
And
get them
as
both
far
on
as
the same day, Jim, a bivalent and a flu shot?
if you think that you're feeling up to it, most people do. We had a number of people here in the clinic this week, and I was even surprised, young, old, medium, that got them together, did very well.
Good.
It's acceptable medically. We'll separate them in different arms if we can. If not, if it has to be the same arm, we'll do them an inch apart. If you feel more comfortable coming back a few days later or a week later, that's fine too. But they're medically compatible as far as an interaction. No need to worry. It's just if you're the kind of person who gets a sore throat, fatigue from flu shots and from COVID shots, and you say, hey, my schedule is such that I have the leisure of being able to schedule 2 appointments. Folks that are a little bit more fast paced with their life, they like to get it over with. Side effects are relatively similar.
And Jim, if I'm in Erie, how do I find out where to go get my shot through your system?
All through our system, so you can access through our LECOM is aging site. We have a number of areas. So we have in operation a live person phone number, which I will leave with you, a live Outlook email account. We also have our Eventbrite site for LECOM clinics that's available for web-based stuff for pre-registration. And even better, we have our walk-in mode for ultimate convenience. So right now we are every Tuesday we are here. We're administering flu and COVID shots from 9 a.m. until 7 p.m. at LECOM Center for Health and Aging at 3910 Schaper Avenue, right off of West 38th Street. On Fridays, we're here from 9 to 5. And we have our special pediatric times where we focus on kids in the 6-month to 5-year category on Tuesdays from 1 p.m. until 5, although we're a little lax and start a little bit early and go a little bit late for moms and dads that have to do that. And on Fridays, we do that for the morning 9 to 1. And so I will forward you our calendar and our numbers and stuff. I'll get you that here right promptly. We're gonna do some changes with our phone system, but we'll make some notifications there for that. We still are offering homebound visits for those that cannot get out. We've done hundreds of them. We've gone into people's houses that don't have the ability to get out because of medical conditions, and we still do that on a regular basis. And we're operating a lot of clinics on the outside too.
Well, Jim, our producer here is waving the red flag, so I have to shut ourselves down. But if you would be so kind as to forward the phone numbers, I'll make sure that they attach this to the end of this broadcast so people can get it. And if worse
Send them right over.
just call LECOM and we'll get you to the right place.
We'll get you. I'll get you some good numbers.
Right place. And Jim, on behalf
Fantastic.
of, I mean, I benefited from your work, and so many people in this community have. We thank you for taking such good care of us and for trying to explain, which I think is confusing to people, what this vaccination is. And more important, if you have a question, ask, but get it, is everybody.
Right.
Thanks, Jim.
Right on the money.
Thank you for joining us on LECOM Health Matters.